Hello, everyone. Thank you for joining WHO EPIWIN webinar today. We are still waiting for participants to join in, but we welcome you already. We can wait for 1 or 2 minutes until everybody has joined, and then we can start. Hello, everyone. Welcome to WHO EPIWIN webinar for today on community-based surveillance. We're just waiting for everyone to join, and then we can start in probably a minute. Thank you. Good afternoon, good morning, and good evening to everyone. We welcome you all, particularly those of you joining from far away or at late or early times. Thank you for joining this WHO EPIWIN webinar, Engaging Communities in Early Outbreak Detection and Response Action through Community-Based Surveillance. Today's webinar is part of a series of EPIWIN webinars on health emergency preparedness and response for community protection. This webinar today is organized by the Interagency Community of Practice for Community-Based Surveillance. For those new to EPIWIN, this is the WHO Information Network for Epidemics for Science and Knowledge Translation in Health Emergencies. Our goal is to translate science in accessible, understandable, and relevant ways for evidence-informed actions and decisions in health emergency preparedness and response. Today, we have a great panel of experts to discuss community-based surveillance. My name is Lester, and I will be hosting today's webinar. For our speakers, we will start with Dr. Kai van Harbo, Unit Head of Community Readiness and Resilience from WHO headquarters. He will give the opening remarks on behalf of Dr. Nedret Emiroglu, and an overview of community protection. We will also hear from Dr. Petra Khoury, Director for Health and Care Department, International Federation of Red Cross and Red Crescent Societies. Then we will hear from Dr. Rim Kwang Il, Team Lead for Community Public Health and Service Delivery under Community Readiness and Resilience from WHO Geneva. He will provide background on community-based surveillance and the work of the Interagency of Community of Practice. We will also have a short video about community-based surveillance. Then we will have 3 distinguished speakers who will present experiences at country level. First, we will have Dr. Jakob Zidstag. He is a veterinarian with a PhD in tropical animal health. Since 2011, he works as Deputy Head of the Department of Epidemiology and Public Health at Swiss Tropical and Public Health Institute. He focuses on the control of zoonosis in developing countries and the provision of healthcare to mobile pastoralists using a One Health approach. He will be talking on integrated environmental, animal, human surveillance response systems in communities in Ethiopia. Our second speaker will be Biwott Hazael. He is a community-based surveillance officer in Kenya Red Cross Society. He will be talking about empowering local communities, the Kenya Red Cross's approach to community-led outbreak detection and response. Our third speaker will be Dr. Arun Balaji, who is currently the Senior Specialist for Pandemic Surveillance at the Global Fund to fight AIDS, tuberculosis, and malaria. She is on secondment from US CDC and has more than a decade of experience implementing early warning surveillance in multiple countries in all WHO regions. She will be talking about overview of Global Fund investments in early warning surveillance, including community-based systems. After the three presentations, we will have the opportunity for question and answer, and we will have a panel of experts from the Interagency Community of Practice for CBS. First, we will have Dr. Rim, as mentioned before. We will have Dr. Hilary Bauer from UK Public Health Rapid Support Team, London School of Hygiene and Tropical Medicine. And we will also be joined by Dr. Philip Ngere from Kenyan Ministry of Health, Division of Disease Surveillance and Response. The question and answer will be moderated by Rachel Gudermote from International Federation of Red Cross and Red Crescent Societies, and will be supported by Patrick Keating from MSF. Before we proceed, here are some housekeeping and reminders. This webinar is being live streamed on the EPIWIN YouTube channel. The webinar is being recorded, and afterwards, the recording will be available from our website. The address will appear in the chat. We invite you all to post your name, location, and organization in the chat box. We would love to hear where you're joining us from. Please add any questions you may have to the Q&A box, not in the chat, so we can more easily keep track of them. So as in the previous webinars, we want to know more a bit about you. To do that, we have a short Slido survey. And for this, I turn over to Supriya. Supriya, over to you. We're waiting for Supriya to unmute, but in case, over to you.
So please join us at slido.com, hashtag 2321213. Right, I think a large majority already are familiar with the concept of community-based surveillance. I will keep this on for if more of you would want to respond. It's at slido.com, hashtag 2321213. But I'll stop sharing my screen now. It's great that most of you are familiar with the concept of community-based surveillance. And I hand over to Lester.
Thank you, Supriya. Thank you, Supriya. It's great to see more than 70% is already familiar with community-based surveillance. So without further ado, I will hand over the floor to Dr. Kai van Harbo for the opening and overview of community protection. Kai.
Thank you very much, Lester, and good afternoon, colleagues. My name is Dr. Kai van Harbo. I'm the unit head for community readiness and resilience here in WHO's Health Emergency Program in Geneva. And I would like to welcome you and thank you for your participation in this meeting. It's really great to see so many colleagues online. We have almost 1,000 attendees already. And I welcome you on behalf of Dr. Nedret Emiroglu, who's our Director for Country Readiness Strengthening here in WHO HQ. Our unit is leading the work of WHO in the area of community protection. which is a new subsystem of our new health emergency prevention, preparedness, response and resilience framework. And we are working this in very close collaboration, in particular with UNICEF and IFRC as our key partners. And it's great to see that events like this that we are organizing together. And thank you very much to Dr. Petra Khoury also for your leadership in this area. And of course, I think many of you are familiar with community protection because we hosted already a number of webinars here on the EPIWIN platform this year. We started with our first partners meeting in April. And then the last webinar we conducted was around community protection and the MPOX response just a few weeks ago. And I think we are really eager to continue this engagement with the colleagues, with the communities through this very important platform. And today, of course, we talk about a really, in particular, a relevant topic for all of us, which is community-based surveillance. And as you know, community protection is really composed of three main pillars that need to come together to ensure community-centered health emergency management. And that is risk communication, community engagement, and infodemic management, which is really all our activities to ensure that communities are provided with the right information, that they are able to make informed decisions, but also that they can actively engage in all decision makings around health emergencies. Then we have a second objective is population and environmental public health interventions. And there we really focus on the community level capacities to prepare and respond to health emergencies. And the third objective is called multi-sectoral action for social and economic protection. And this really focuses on minimizing secondary impacts from health emergencies around social protection, livelihoods, education, food security, psychosocial support, etc. And today's webinar focuses on the second objective. And here, of course, in particular on the role of communities and the community workforce in early detection and response. And this is really an essential component of the community-centered approach that we are advocating for. And we will hear much more about how communities can take an active part in preventing and responding to outbreaks, in particular through early detection and then a local response. And we will hear practical examples from different settings, and I really look forward to these discussions. And we will discuss more about the role of community health workers and volunteers, which are very important stakeholders in this context, but also on how the national level can strengthen these interventions at the community level within the national surveillance and health security system, which is, of course, very relevant for all of us. And community-based surveillance is also an area that we are focusing on in the MPOX response. And this is really the first emergency where we apply the community protection approach in an emergency response to a public health emergency of international concern. And I think you heard more about this in our last webinar, but I'm sure we will have some examples and touch upon this also during the discussions today. And of course, community-based surveillance is also an area where we collaborate particularly close with the IFRC as a co-host for the interagency committee of practice for community-based surveillance that was mentioned already, and that we will hear much more about in the coming discussions. So I really hope that this webinar will be useful, that will give you some very practical examples on this very important topic. And I look forward to enriching discussions today. Thank you.
Thank you very much, Kai. Now let me introduce you to Dr. Petra Khoury for a short keynote on building health resilience through community-based surveillance in the Red Cross and Red Crescent. Over to you, Dr. Petra.
Thank you. Good morning, good afternoon, colleagues. I would like to echo what Kai said about the collaboration and the partnership that we're doing across our organizations. And we're very proud to be part of these EPI webinar for a few times this year, where we shared the work that the WHO, UNICEF, IFRC, we do together to bring the world into a healthier place. Community-based surveillance that is done through the Red Cross, Red Crescent societies is essential for building what we call community health resilience. It is supported, our solution is supported by over 23 Red Cross, Red Crescent societies and a network of millions of volunteers. The solution extends life-saving public health measures to remote and vulnerable areas, and that's where the value of the work on community-based surveillance that we do brings to the national system. This system mobilizes local volunteers to detect, report, and respond to unusual health events quickly, forming an early warning mechanism that can prevent outbreaks before they escalate. Increasingly, CBS is being digitized across many countries, which enables faster, more accurate data collection and reporting. Through simple SMS text messages and digital platforms, volunteers can now record health events in real time, strengthening early detection capabilities and supporting more efficient responses. By integrating a One Health perspective, CBS also addresses interconnected health risks across human, animal, and environmental factors. This approach has proven effective in responding to health crises such as Ebola, COVID-19, and the latest Mpox outbreak, where the collaboration between communities and public health systems ensured rapid containment and mitigation efforts. Being operational in multiple countries, CBS supports global health security by placing communities at the center of health surveillance. It reflects the Red Cross Red Crescent's commitment to sustainable public health solutions, where local actors are empowered to protect both human health and environmental stability. Through CBS, the IFRC fosters resilience, amplifies local knowledge, and builds a safer, more prepared world for all. I'd like to thank you once again and wish you an informed session. Thank you.
Thank you very much, Dr. Petra. Let me now turn over the floor to Dr. Rim of WHO CRR to provide us the context of community-based detection and response capacities through community-based surveillance. Over to you, Rim.
Thank you very much, Lester. Good morning and good afternoon and good evening, colleagues. My name is Kwang-il Lim, as already introduced by Lester, and leading the team of Community Service Delivery Team in Community Readiness Resilience Unit. Happy to be here today with all of you. So, since the previous speakers, Dr. Kai and Dr. Petra already highlighted the importance of community-based detection and response through community-based surveillance in the context of community protection of HEPA, I'll be briefly complement some technical aspects. So, next, please. Reflecting on past emergencies, including the COVID-19 pandemic, it is clearly evident that these emergencies begin at the community level. Therefore, it is crucial that to build capacities and establish mechanisms within the community to detect outbreak early and contain them before they escalate into major outbreak or even pandemic. Communities also have played critical role in emergency response, including case finding and timely referral, and also contact tracing. Next, please. Next, please. WHO has integrated this core principle that health emergencies start and end within the community into the global health emergency management architecture, which we call HEPA, already mentioned by Kai, by placing communities at the center and also designating community protection as one of the 5 system areas of the HEPA framework. The HEPA framework promotes greater collaboration and synergy between health system strengthening and resilience building in tandem with community resilience. It also addresses social determinants of health through a multi-sectoral approach and broader partnership at all levels, including local and community level. Next, please. There are 3 key objectives in the community protection of HEPA, as already highlighted by Kai. For us as technical agencies, it is crucial to define and also articulate key functions and capabilities required to build or strengthen community protection. This will enable us to operationalize community protection effectively across all phases of the health emergency cycle. Next, please. Next. Yeah. One key point I want to emphasize is that adopting a systems approach to community protection. This means strengthening community systems and resilience by leveraging existing structures like community health committee, which function well in many countries, as well as community organizations and networks, and also integrating community-based public health service into primary health care, building the capacity of community health workers and volunteers through regular training, which is essential for early detection, notification, and also other community-based services. We must avoid overwhelming communities with numerous requests coming from various political programs. Instead, we should co-develop and implement interventions and services with the communities. It is also crucial to ensure functional and operational linkages between communities and community-based health systems, such as primary healthcare centers, and also local public health systems, include rapid response teams. Next, please. This slide presents a generic example of national surveillance system. Many countries have multiple surveillance programs, such as EWOS or IDSR for notifiable communicable diseases, whether indicator-based surveillance or event-based surveillance. Surveillance systems for particular programs like vaccine-preventable diseases, including measles, and also disease-specific programs for arbovirus, for instance, dengue and chikungunya, and also central surveillance for influenza-like illnesses and also severe acute respiratory infections. What is critical is how these various surveillance programs and also data collection platforms interface with the communities, and also how to systematically integrate them through relevant and appropriate mechanisms, procedures, and platforms, which are streamlined at the interface between communities and health system, primary health system, particularly at the local level. Next, please. The last global consultation on community-based surveillance took place in 2018 in Lyon. During this meeting, the definition of CBS was agreed upon, and also several important communication recommendations were made to address the issues and challenges of implementing CBS in countries. Key issue identified was the integration of CBS into national surveillance system, which remains relevant today. The meeting also emphasized the importance of collaboration between government, communities, and partners, strengthening the community workforce, and also linking CBS with other community services. Next, please. One of the key recommendations from this consultation was to establish a community of practice on CBS to create a space for collaboration and exchange of ideas and experiences and opportunities. Following this recommendation in September last year, WHO and IFRS initiated establishment of an interagency community of practice on CBS involving many global partners as listed in this slide. This community of practice has met multiple times already to discuss important issues and recently led the development of interim guidance on strengthening community detection and response during the mpox outbreak, which is now moving towards final publication. Today's webinar also organized through this collaboration platform. Next, please. This is my final slide to kind of highlight some of the potential focus areas. First, integrating CBS as an integral part of national surveillance response system, which is key, as we discussed previously, and also systematically engaging communities by maximizing existing structures and networks rather than introducing new ones. Third one is ensuring that detection and reporting are functionally and also operationally linked with other community-based interventions and services, such as community infection prevention control and WASH, and also health promotion and mental and psychosocial support. We have developed, WHO have developed an integrated training package for community health workers and volunteers on this aspect, and I'm happy to discuss and implement it if anyone is interested. And also capacity building of community health workforce, and then enhancing global partnership and also investment for localized action, which are critical for this for the success. I will stop here. Over to you, Lester.
Thank you very much, Rin, for giving us an overview of community-based surveillance and also the work of WHO and the community of practice. Now, before we proceed, we will show you a short video on community-based surveillance. We are requesting Rachel of IFRC to play us the video. Rachel, thank you. Thank you so much, Dr. Kai, Petra, and Rim, for giving us an overview and setting up the context about CBS. Thanks also to IFRC for the short video. Now we have a good overview of community-based surveillance and what it can do at the community level. Let me call on our first speaker, Jakob Zinstag. And also checking our presentation, and we had an earlier difficulty, but I hope this will work better. All right. So over to you, Jakob.
Thank you very much, Lester. Hello, everybody. It is a great privilege and honor for me to talk to you today about the theory of integrated environmental animal-human surveillance response systems. And I would like to give you the example of integrated small-scale community-based surveillance response systems in the southeastern Ethiopia in the Somali region. This work is done by Yahya Osman, a PhD student from Chichiga University, who does this work in the field. Next slide, please. So the idea of integrated surveillance is not new. This is a quote from our paper in 2005 with regard to the H5N1 avian influenza pandemic, where we already say we must reduce the interactions of humans and livestock that are risky for transmission of zoonotic diseases. Next slide. Already in 2012, the World Bank proposed this schematic, meaning that if we discover a new disease in wildlife or the environment, the related cost, cumulative cost, which is represented by the red line, are low. But as soon as the disease enters into livestock, causes livestock disease, or enters into humans and causing mortalities in humans, the cumulative cost rapidly increase. So this is the main argument to join surveillance systems between humans and animals. Next slide, please. We have summarized this again in this article in Lancet on advancing one human-animal environment health for global health security. In this paper, we present again the schematic of the World Bank. Next slide. And the prevailing surveillance constituency. So we have the international health regulations that look after human health surveillance, and we have the performance of veterinary services of the World Organization of Animal Health that looks after surveillance in animals. This is the current state in most countries of the world. Surveillance systems are in separation. Through a progressive One Health governance, we hope to bring together these systems together. Next slide. Through a One Health governance, we hope to interconnect the international health regulations and the performance of veterinary services to improve communication between the sectors. Next slide. Ultimately, the vision is that in an optimal One Health governance, the surveillance systems between environment, humans and animals are completely integrated and communicate closely with each other. And this should maybe not prevent new emerging diseases, but at least massively reduce the cumulative cost of the outbreaks. Next slide. This is not a idea that is impossible. We have already an example in northern Italy of the integrated West Nile virus surveillance systems for mosquitoes, wild birds, horses, and humans in the same time. And this system already saves money by improved communication. Next slide. To really prevent the next pandemic, we must urgently improve the biosecurity at the animal and the animal welfare in livestock production, transport, and marketing. The pictures that you see here are inhumane. The animals that are transported on this motorbike are hugely stressed, and they would shed more virus because of the immune suppression. So next slide. So we call actually for a UN Convention on Animal Health and Protection as part of pandemic prevention. Next slide. So the Chichiga University One Health Initiative in Eastern Ethiopia is a partnership between Chichiga University, Swiss Tropical and Public Health Institute, and the Armauer Hansen Research Institute. Next slide. In this project, we have established the integrated surveillance response system in Adadle Woreda, and we are about to do it in Shinile Woreda, 2 districts in the Somali region. On the left side, you see the office of the integrated surveillance unit with a veterinary officer, a public health officer, and on the right side, Yahya Osman, the PhD student. They are in direct contact with village health workers. On the right side, we also organized a community-led small-scale health insurance that collects every month very little amount of money and allows to evacuate patients and buy the fuel and pay the driver to do that. Next slide. So the One Health Surveillance Unit is integrated in the national surveillance systems at the animal level and the human level from the villages, the Kebeles, the district, the region, and the federal level of the Ethiopian government. Next slide. So the key of the surveillance system are really the community health workers and the community animal health workers in the picture on the bottom. These people are the first line of surveillance. If they observe a sick child or a woman that is in labor that needs evacuation, or if they observe dead animals, they immediately communicate it by direct calls or also newly by an application. And then the team can send a motorbike to collect samples freshly in the field. So we massively reduce the time to detection, number one, and we establish also a very good dialogue between community animal health workers and community health workers. In this way, next slide, we can clearly distinguish a number of purely human disease like malaria or measles, and on the animal side like contagious caprine pleuropneumonia or camelpox or blackleg, but also many diseases that are zoonotic, that are really transmitted between humans and animals like anthrax, rabies, avian influenza or Rift Valley fever. And these diseases, we can substantially reduce exposure and reduce time to detection. Next slide. Here you just see examples on top of anthrax and also diseases of unknown origin, mainly in animals, but we see this also in humans because we are so close to the communities. We would never see these cases if we wait on health centers or hospitals or veterinary posts for people to show us these cases. Next slide. So we can summarize integrated surveillance response systems at community level. They reduce time to detection because if we detect the disease already in the wildlife or in the domestic animal and communicate it, we can already inform public health and reduce the time to detection. We can also delay the time of first emergence if people protect themselves better. For example, in the case of Rift Valley fever, we were able to inform communities not to touch aborted fetuses and also not to drink milk. So in this way, we can delay the time of first emergence because we reduce exposure. And we also reduce burden because by the reduced exposure, the cumulative number of cases can be reduced. At the end of the day, this will also be less costly, and I'm sure we can make savings compared to separated surveillance system. Thank you very much for your attention.
Thank you very much, Jakob, for a beautiful presentation showing the linkages through One Health approach, integration at all levels, and really the role of community health workers and community animal health workers. So we have a number of human and zoonotic diseases there that are being detected through this system in Ethiopia. Thank you so much. Now we move on to the next presentation by Biwot Hazael from Kenya Red Cross Society. Biwot?
Yes, thank you so much. You could bring the presentation to... Yes, thank you so much. This is Biwot Hazael. I work for Kenya Red Cross as a community-based surveillance officer. And thank you for this opportunity to present Kenya Red Cross work on how we empower and engage communities in outbreak preparedness to enhance early detection that leads to early warning and, of course, leading to local response. Next. So Kenya Red Cross, and this is the approach, Kenya Red Cross implements a global health security program being funded by USAID, getting technical support from the IFRC, called CP3, Community Epidemic and Pandemic Preparedness in 6 counties, as you can see in the map. The program has adopted a community-led approach to outbreak detection and, of course, in communities through engagement of community health promoters and community health promoters within the government structure of primary health care at the level 1 of communities. We also involve community members, community leaders, and community-based key stakeholders. The aim of this program is to strengthen, of course, the ability of the communities, as I have said, the Kenya Red Cross itself, because we are auxiliary to the government and the county governments, the implementing counties and other partners, of course, to 1, prevent, and 2, to enhance early detection and response to diseases and prepare for future risk as stipulated in the Global Health Security Agenda. Next. The strategy that this program uses is One Health approach, and One Health approach is used in various areas. Of course, one, risk communication and community engagement, where we engage communities to, of course, communicate health risks and how they can control them in their own communities. We also use One Health approach in community-based surveillance. In the table on your right, you can see we are tracking key health risks with regards to human health and animal health. And for human alerts, we look into some disease-based alerts, one severe water diarrhea for cholera. We also look into fever with rash for measles. We also adopted recently fever with rash for mpox, and then sudden paralysis for AFP and polio, fever and unusual bleeding for viral hemorrhagic fevers. And then we have one event of cluster of unusual illness or deaths of people in the communities, and this is an event where more than 3 people are sick or have died. For health risks with regards to animals, we are looking into cluster of livestock abortions, and this is for RVF and other diseases, aggressive animal rabies signs for, of course, rabies. And then we have an event, of course, of cluster of unusual animal illness where 3 or more animals are sick, and then deaths with unusual bleeding for anthrax. We also track activeness of the volunteers in the communities. The workforce that supports this work is, we have 2,042 community health promoters. We've trained them on 2 basic modules, that is on epidemic preparedness in communities and community-based surveillance. In addition, are the supervisors for these community health promoters, who are the community health assistants, who are government healthcare workers, and 126 animal health assistants. Sometimes we draw private practitioners to fill in the gap of animal health assistants, subject to, of course, limited human resource within the veterinary sector. We also support coordination meetings, and these are at the counties. We want to operationalize One Health units at the counties and the sub-counties, and that is what we support these county One Health unit meetings to enhance coordination and communication for early preparedness and response. We do also do periodic community health unit meetings on quarterly basis, and even at community health levels to develop community action plans for health risks of concern. The program has adopted a community health strategy program. This is a government-led program under the primary health care at the community levels to enhance awareness creation. Next. So since 2019, when we started this program, as you can see in these slides, we've managed to, or the communities have managed to submit alerts, and our alerts are defined into 2, false and true alerts. True alerts, it means that these are alerts that meet defined community case definitions. These are not medical definitions, but community case definitions that communities understand well in their communities. And the false alerts are those that have not met the community case definitions. So the highest number of alerts that have been received are the first 2 of animal rabies and unusual animal illness in the communities. 280 animal rabies were confirmed as true alerts, meaning it met community case definitions. And then the next level now goes to verification and investigation with the authorities to confirm these either through lab diagnosis or clinical diagnosis. The list is viral hemorrhagic fevers, subject to, of course, in Kenya, it's not high risk like in the West African countries where you would find VHFs as are many. Next. So a case scenario of key successes in outbreak preparedness and response was in May and June in one of the counties called Narok. We had an alert that was submitted by one of the community health promoters. As you can see in the right side, an alert of unusual animal deaths from one village in called Sosiana, where it claimed 6 herds of cattle. Subject to early response, 4 carcasses were properly disposed by burying, but unfortunately 2 carcasses were consumed by the community members, where 70 people from 15 households consumed the 2 carcasses of these dead cattle. 13 people hospitalized, and they were discharged well, courtesy, of course, of the engagements with community health assistants, animal health assistants, and the community health promoters. This early detection triggered an animal ring vaccination that was conducted by the government, reaching 2,909 cattle. If this was not determined or detected early, then people would have consumed all the 6 carcasses, and you would be speaking of so many people being hospitalized. We would also be reporting some fatalities out of this, but again, subject to early detection, then the community health promoters and the communities managed to detect it early and vaccinated these animals in the communities. Next. Again, we also attribute this community-based surveillance to have triggered animal vaccination. And with regards to only the animal health sector, we have seen some of the vaccinations being done in anthrax, and these are being triggered by the reported alerts. For anthrax, you can see the numbers, rabies, and then the last three diseases are diseases of cluster of unusual animal deaths. More than 3 animals are dying or are sick in the communities, and the community health promoters are reporting. And courtesy of this, we detect other diseases of concern. It is of concern to these communities because of economic importance. We deal with pastoral communities, and if their livelihood is affected, then again, the livelihoods and the health and well-being of these communities will be affected. So again, you see this has triggered so many vaccinations with regards to the other diseases of concern that we are not detecting. Next. So the key achievements that we are attributing to, of course, engaging communities and empowering communities to support us in early detection and response is one, it is supporting decision-making. As you can see in the slide, the last slide on animal vaccination, data readiness, availability of data triggers animal health vaccination campaigns by the authorities. And then also CBS data is being used to influence behavior change communications. Communities would tend to change their behaviors based on true things that are being found in their communities. A case scenario of the anthrax case that was found in the community, it led to communities disposing the carcasses subject to availability of that disease. So once the community has detected a case, then you can use the case to further influence behavior change communication. There's also strengthened partnerships, and we are seeing some other partners coming in because of available data. PSF Germany is supporting with rabies vaccinations in Narok and Baringo counties. We have also Boringa in Claim that is supporting with school health programming and the provision of rabies vaccines with areas that we have detected rabies cases in these areas. Also, data from CBS is being used to inform health planning and financing, where we see counties procuring human rabies vaccines due to sustained advocacy that I said we support coordination of efforts in the counties. So these efforts are really good so that it supports us advocacy for these counties to procure and plan for other drugs effectively. And also the demand creation that the communities are demanding leads to planning for these counties. And also one county procured animal rabies vaccines in the financial year 2023-2024 just to, of course, meet the demand of the communities. Next slide. So we have testimonials from some of the communities. You can scan the QR code and you can watch a video of some of the testimonials that we have had in the communities and how the communities are really appreciating this work. Now we are empowering them and engaging them to support us with early detection of diseases that leads to early warning and, of course, enhances local response to this. For us, we say epidemic starts and ends in communities. That is our mantra. And we would want to focus on communities to enhance global security agenda. Thank you so much, and that is it from my end.
Thank you very much, Biwot, and thanks for giving us a very recent example of how community-based surveillance triggered animal vaccination. So that's an example of community response, community-level response. We already heard 2 examples from African countries. I'm now turning over to Irene Balaji, who will give us overview of global fund investments in early warning surveillance, including community-based systems, and maybe mention other countries in other regions as well. Aaron?
Thank you very much, Lester. Can we see the presentation? I'm not seeing the presentation. Thank you. Thank you very much. Hello, everyone. Today, I will be sharing with you an overview of the Global Fund investments in early warning surveillance that includes community-based systems, and then also provide you some of the early learnings we've had investing in early warning surveillance systems. Next slide, please. As you can see here, the Global Fund has invested about $270 million in surveillance system, largely in systems that strengthen early warning surveillance and data systems for detection and reporting of epidemic-prone diseases. And these fundings to the countries have come in response to the country demand for strengthening surveillance systems, targeting gaps in post-COVID assessments, and national action plans for health security. Next slide, please. So this slide gives you an illustration of the areas of activities that the investments of the Global Fund goes to support. The early warning surveillance approach really, we think, is an end-to-end approach where all of the systems that include event-based surveillance, indicator-based surveillance systems will be strengthened. Data systems that include collection and reporting of data will also be strengthened, as well as systems that allow multiple data streams to be collated, data to be analyzed, interpreted, and therefore used for public health action. This also includes laboratory and other multi-sectoral data. These are the systems that we're supporting through Global Fund investments currently. Next slide, please. And as you heard from both of my colleagues in the previous presentation, our approach is also multi-sectorial. It spans strengthening human health sectoral participation, as well as animal health, environmental health, that also includes climate. Next slide, please. So this is a snapshot of countries that are predominantly using Global Fund investments to strengthen community-based surveillance. Indonesia is not here, but I also know that Indonesia is also strengthening, as we speak, their community-based surveillance and digital systems to improve event-based surveillance in that country. Next slide, please. So my colleagues also gave you an example, several examples of why community-based surveillance is important. This is a retrospective analysis done by my colleagues from Madagascar, which reinforces the concept of the communities to be the center of epidemic reporting and pandemic preparedness. So if you look at this, this happened about last year. The 12th September 2023, a patient with plague-like symptoms went to a primary health unit. The primary health unit recognized that this was a case of suspect plague, but instead of responding or reporting up immediately, plague is an immediately notifiable disease in Madagascar. They included that in their weekly reporting and sent it up to the district level. On 14 September 2023, the district received aggregated report of all notifiable diseases and other diseases from the primary health unit, and they missed the plague case because this was aggregated reporting. No response was initiated. 15 days later, and this was 18 days from the first case that showed up on the primary health unit, a community health volunteer, a very vigilant community health volunteer, noticed 2 deaths in the community, and both of the deaths were because of plague-like signs and symptoms. They reported to their district level authorities, and the district started investigating and immediately reported it up to the regional and national level. Subsequently, the national level sent rapid response teams. 2 days later, an outbreak was declared by the Ministry of Health, and WHO notified. This outbreak resulted in 11 cases, 5 deaths, with a CFR rate of 45.5%. A lot of lessons were learned, and Global Fund investments are going to Madagascar and strengthening a lot of the gaps that were revealed by this retrospective analysis. Clearly, the strengthening of community health volunteers is an important gap, and expansion of community health volunteer work in Madagascar is ongoing. But we also realized that there are also other gaps, including strengthening the need to strengthen the primary health units, as well as the district in understanding notifiable disease detection and reporting, and immediate reporting and response that needs to be taken for these kinds of reports that come in. Next slide, please. This is one other illustration where we're making significant advance in collectively reinforcing not only the community health workers and community networks to report, but also the public health systems itself, including the districts, to really understand to the signals that are reporting, to understand when to respond and how to respond. And we are using, along with the Ministry of Malawi, measurement framework 717 at the district level to continuously monitor and understand the impact of global fund investments. Here in these two tables, you can see that the two districts have significantly improved their detection, notification, and response times to two different outbreaks, one measles and the other cholera. Next slide, please. So this is my one slide before my last. I just wanted to, we're at the Global Fund, along with our Ministry of Health partners, we're gathering early lessons learned. And I just wanted to highlight some of this for this audience. First, it's very clear and apparent that careful design of an event-based surveillance, including community-based surveillance systems, very important for the utility and sustainability of these systems. The signals or alerts need to be designed to balance both sensitivity and specificity. The number of signals that we're asking the communities to report also needs to be negotiated. It cannot be a long list. It needs to be a carefully designed number of signals so that the community health workers are not overburdened. Dr. Rim talked about this. Deliberate inclusion of communities and community networks and key focal points for event detection is an important hallmark of community event-based surveillance, where we rely on communities to detect early, but use the community health workers as gatekeepers of the public health system so that we don't overburden the community health workers. We also are learning that continuous mentoring and routine supervision of community health workers, the communities, and the districts are very important in addition to trainings. Second, we're also learning that optimal implementation of community-based surveillance requires capacity building of the entire public health ecosystem, because we need the public health units to understand triage and verification, investigate appropriately, do risk assessments optimally, and respond accordingly. So strengthening of the entire ecosystem, not only the communities, are very important. We're also finding continued challenges in the sustainability of community health workers. As we increase the workload of community health workers, we need to find ways of really understanding how much community health workers can do, what is the most important priorities for community health workers, and therefore surveillance itself doesn't become jeopardized because of the work of community health workers. As we all know, there's also continued siloed support of community health workers by donors, and that challenges the sustainability of community health workers. We're continuously finding that community-based surveillance is a very important component of early warning surveillance, but these are being implemented in countries as small pilots, and time has come to scale these up with the coordinations of ministries of health where relevant. Next slide, please. This is my last slide. Looking forward, the Global Fund continues to encourage partner countries to use normative WHO and Africa CDC guidelines to design optimal event-based surveillance systems. There is a seminar upcoming next week on really talking about, along with WHO Afro and Africa CDC, talking about how to design these signals so that you can achieve optimal balance in these kinds of systems. We're going to invest in continuous monitoring so that we can improve these systems. We'll also continue to invest in the entire public health ecosystem so that capacity building can also strengthen subnational levels. We're beginning the work to cross sectoral collaboration within the Ministry of Health so that we can ensure sustainability of community health worker engagement. The Global Fund is planning to leverage and is already leveraging several investments we're making in HIV, TB, malaria for community health workforce. We're also working with our technical partner to develop measurement standards to better document the impact of event-based surveillance in these communities. Next slide, please. So this is my last slide. I want to thank you for the opportunity to present some of the work Global Fund is doing on the ground and some of our partners represented here, including community health workers in different countries that we work. Thank you very much, Lester, and over to you.
Thank you very much, Aaron, and thanks for giving us a background also on the investments and global funding for community-based surveillance, the importance of different partnerships, and we already have an idea of the different countries around the world who are also implementing, and many, of course, are also being done by other partners. I think we see already many comments for question and answer. But before that, we can have another quick Slido survey, and I'll turn over to Supriya for the Slido survey. Also, we received some inquiries on the certificates. So after the surveys, Supriya can also give some announcements on the certificates. Supriya?
Thanks very much, Lester. And hello, everyone. Once again, we come back to the Slido, slido.com, #2321213. So please go there or scan the QR code from the screen. Yeah, we're getting great. We are getting some responses now. Okay, most of the people are now currently doing other functions and want to know more about CBS, but you still have a number of people engaged at the community level, subnational level, and changing. So keep those answers coming. Great to hear from you. While you're doing the Slido, let me also, since there are so many questions on certificates, let me explain to you that, and those of you who are regulars in EPIWIN will know, EPIWIN is a knowledge sharing platform. It's a just-in-time knowledge sharing platform. We like to have an exchange of information with all of you. It is not a training platform. So we do not automatically give certificates. We do, however, give certificates to those who respond to our survey within 24 hours. And in that survey, actually indicate that they want a certificate. Even if you respond to the survey, if you don't indicate that you want a certificate and don't give your name, then we will not send you a certificate. But we would like our information to have an impact on the ground. So to get a certificate, the most important thing is, please explain to us how you will use this information. That is very important for us. We want this webinar to be useful. So those are the conditions for the certificate. And if you've met all those conditions, you will get a certificate. There has been a slight delay. We are currently have an acute manpower shortage. So we are sending certificates slowly. We're catching up on the backlog. So please bear with us, be patient with us. But if you meet those criteria, you will get a certificate. Don't worry about that. And the questions about whether the presentations will be shared, they will be shared. They will be on our website, and I've put it on the chat as well, the website, epiwin.who.int. And we will also be sharing it through the email to all the registrants eventually. Again, because of slight shortage in manpower, that's slightly delayed, but all registrants will get the recording and the presentations. Thank you. And with that, we have more than 216, almost 270 responses. So great. Most people want to know more about CBS, but there are a number of people engaged at the subnational and community level. I will leave this on as usual, but I'm not sharing my screen anymore. Go to slido.com, #2321213. Thank you. Over to Lester and Rachel.
Thank you very much, Supriya. So we see there around 50% of our audience are actually doing work on CBS at different levels, from community level and going up. And of course, we have around 1/3 who are also interested to learn more about this. Now is the time for question and answer, and we have around 20 minutes. So I turn over to Rachel and our excellent panelists from the community of practice. Rachel, over to you.
Thank you so much, Lester. And to kick it off, just a huge thank you to all of the colleagues who shared at the beginning and gave the presentations. I think from the comments and also the Q&A section, which we will try to answer both online as well as in the comments as well. There's been a lot of engagement and a lot of interest in this topic, so it's very exciting to see. My first question will combine a couple things, and I think, Rim, if it's okay for you, I think you would be well placed to answer it. So there have been several questions about challenges in integrating community-based surveillance into national surveillance systems and how they can link and align to these surveillance systems, how you've seen it work, what challenges you've seen, or anything else you'd like to share in your experiences on this. Thank you.
Thank you very much, Rachel. Also, thank you very much, colleagues. I think the question coming is really relevant. And in the context of CBS, and also, as I mentioned in my slides already, that the couple of important points, integration of this community-based surveillance into national surveillance system. And also other colleagues, speakers also highlighted importance of that aspect. So my role is just kind of a little bit complement from those already mentioned. I think from CBS perspective, I think linking with this country national surveillance, for instance, particularly this EWOS or IDSR, which is key to make sure that the detection of any public health event early and also respond quickly so that prevent the outbreak become bigger. I think this is a key, which is we learn a lot from many emergencies, particularly in COVID-19. So CBS really can leverage community members to detect and report those unusual health events quickly and early, and also especially in remote or underserved area where national surveillance system might have limited reach. And but then important thing is that how this interface between national surveillance system and community. We really need to have capacity in place at the community level to quickly detect and notify, as well as respond together with the national surveillance system through timely investigation and also risk assessment that need to lead to decision making timely, so that the measures and the interventions reach to the community quickly to prevent outbreak become bigger and also control it. I think this is one of the important aspects that we need to make sure that mechanisms in place, procedures in place, and streamline from community to reaching to surveillance system at the local first of all, then it reach out all the way sub-national and national level. I think this full integration of functions and operations are quite important. Second, I think CBS can do a lot in terms of filling the surveillance gap. And CBS can provide critical information from the community level that might not be captured by national system. This includes data on health risk, and also symptoms, and also environmental factors that already mentioned, and that could indicate potential outbreak. I think this is also a critical issue, and also systematic engagement of community. So by involving community members, CBS can bring local ownership as well as build the trust between community and health response providers, and also encourage collaboration between community and health system. I think this is a key element. This participatory approach will really enhance the acceptability and also effectiveness of surveillance activities at the community level. And also CBS is basically designed to work in collaboration with national health authorities. So CBS will really complement existing systems by providing additional data and insight which can be integrated into national database for more comprehensive surveillance network. And also real-time data utilization, which is important aspect that several community-based surveillance projects already using several data collection platform and IT technology to really collect and transmit the data in real time, which will allow for timely decision-making and response at the national level. So overall, CBS really enhanced overall outreach and also responsiveness and also effectiveness of national surveillance system, particularly in resource limited settings. So I will stop here. Thank you very much. Over to you, Rachel.
Great. Thank you so much. Actually, I think this brings it to a great point as well. So some of the questions addressed, I think Dr. Philip Ngere would be a really great person to answer from Ministry of Health in Kenya. Linked to some of the discussion that Rim just answered, I'm curious from your perspective from the Ministry of Health, some of the benefits you've been able to observe in the incorporation of community-based surveillance, especially into local or district level surveillance systems and the EBS system in Kenya. If you'd be able to share some examples or also some challenges that you've had on that, and then also what you might see in terms of sustainability and ensuring that this process can continue to grow in Kenya.
Yeah, thank you so much, team. Sorry, I dropped off because of a power outage that caused this, connectivity issues. Yeah, so for Kenya, for a while, we've been struggling with the community-based surveillance. The country does public health surveillance in the context of using the IDSR strategy, which is an Afro strategy, and this strategy begins from the national level to the community level. And since the inception of community IDSR strategy in the country, I think from the year 2001, we've not been able to effectively engage the communities in public health surveillance. For a while, we've had our event-based surveillance well thought out, thanks to Dr. Arun Belaji, who was in this call, and a number of colleagues, and of course, agencies like the Kenya Red Cross Society, where the WAT is working. We've been able to have our event-based surveillance at the community level well thought out and concretized and functioning. The challenge we've had is on how to roll it, increase the coverage so that the entire country is on board. So this has been there for a while until recently, the current regime, we had community health services becoming a flagship project for the presidency. And this has seen community health services being expanded and rolled out nationally. And we've taken advantage of this as surveillance so that we ride on this to make sure that community-based surveillance also tags along other community health services, and we get that national outlook. So as we speak now, we've developed a curriculum for community-based surveillance, which incorporates community event-based surveillance and community disease-based surveillance that looks at priority diseases. Moving forward, we are going to ride on this community health services that has gone national, so that we also have public health surveillance at the community front goes national. One of the enablers that we've had, and we capitalizing on this to make things happen, is that we have digital reporting platforms that are real time and are centrally paid, so that the reporting entity at the community front doesn't have to incur costs. This has worked fairly successfully for us in event-based surveillance, and we are adopting the same process in community based surveillance. And one of the challenges that came up recently when we are looking into this is we have quite a number of entities or agencies interested in this space and with different platforms for reporting. And I'm happy to report that with the support of our partners and in collaboration with partners, including the Kenya Red Cross, we've had meetings and came up with an interoperability layer, what we are calling the EBS Connect, where agencies can share data of interest and also can pull and push data of interest, so that we don't have this challenge of having one single platform that addresses everybody's needs, but we have agency-specific platforms that are able to speak to each other. As we speak now, we've been able to develop this and pilot it. And it is something that we are waiting for, the green light from the management so that we're able to deploy it. I'm happy that partners have embraced this. They have been onboarded on this, including some of us who are on this call. I don't know whether this speaks to the question or the concern. If not, then I'll be happy to provide additional information. Thank you, and back to you.
That's great. Thank you very much for that response. I think it's really great to hear also from the Ministry of Health side, as I know there are several questions about working with various partners and how everything gets integrated in the end. So thank you for that feedback. My next question is, I'm just going to jump over to Hillary, given your experience working in various contexts and including emergency contexts, implementing CBS, which stands for community-based surveillance. We're wondering, I've seen several questions about addressing community concerns and engaging with communities on risk communication, community engagement, and also trying to address and ensure that no more stigma is caused through the process of CBS. Sometimes this is extra challenging during public health emergencies, for which I know you're very experienced with. I'm wondering if you have any good examples of how this has been addressed in your experience. Thanks.
Thanks, Rachel. And I've seen on the chat a lot of discussion around this. I think what I would like to say first, as a sort of foundation of this, is a lot of times we talk about engaging or involving the community. But if I may, and I'm sure this doesn't apply to all the people on this, that often means go and telling them what to do. Now, if you really want a community, and there are many different aspects, as you know, many different parts of a community, to be involved in something, they need to be involved in a real way, early on, in, if not necessarily designing a system from scratch, at least allowing some input and some working with a system. Now, we're talking, again, people have mentioned CBS, community-based surveillance, and we have community health workers, we have indicator-based surveillance within community-based surveillance, but we also have community event-based surveillance, which involves community leaders as well as community health workers. And I think I noticed a question from somebody saying, is it essential to do a stakeholder mapping? And in this, whether you're in a conflict setting or an outbreak setting or in a normal setting, actually really understanding the different elements in your community, who the communities, and I'm going to say plural because it's not only one, who they see as their leaders, who they trust, who they have confidence in. These are things that will allow you to start functioning with a community as a partner, rather than we know best, we're coming in. One of the things with regard to health promotion and risk communication is that there is often a tendency to assume that only a basic level of knowledge is needed. And again, you go back to, if you're really understanding your communities, because within one area, you may have very different ones, and what that demand for information is, and therefore also what capacity there is to supply information. So this gives me, again, I want to say something about the two-way communication. So risk communication, we tell people, hopefully we answer their questions, we find out what they want to know about a disease or about an event, and we try to help them understand it better. But if we're collecting community-based surveillance, whether that's event-based or indicator-based information, but we never really feed back. So we never really allow that community who's given the information to say, okay, I want the authorities to do certain things around this disease outbreak, but our community also want to have the information so that we can think about and think with you, the authorities or the interveners, to be able to bring something to protect ourselves. Now, I will address this issue of complex emergencies or complex situations, is that obviously that there are many fears and many concerns. There's much politics around it. There may be aspects of a community dynamics that are not immediately visible. Those of you who are working in your own communities, you're going to know this pretty well, but you want to really look at who are the communities I'm missing? Are there hidden communities? Are there groups that I am not actually receiving data from? And in those different groups, what are the sensitivities and what is the way that I can support them feeling like they are really involved in this for their own protection and their own benefit in detecting these diseases. So I think just to sort of not go on too much, I'm sure you've got the message, and I think also many of you are working in your communities, you know that it's not one size fits all. So really understanding and involving, and by involving, I mean really involving, not just saying, we're going to do this, you know, do you want to come to a meeting? Really involving a community from as early as possible is a way to deal with it, whether you're in a nice, stable setting, an urban setting, or in a conflict setting. That would be my suggestion. Over.
Thank you so much, Hilary. I think you've actually addressed a couple of the recurring comments and themes all in one, which was fantastic. And also, as you mentioned, extremely important to the success of moving community event or community indicator-based surveillance forward. So thank you for that. I believe Dr. Jakob has a couple other things to add, perhaps on that comment, and then we will go to one of the other reoccurring questions in the chat. Thank you. Go ahead.
Thank you, Hilary. I would like to essentially second you and say that in in One Health research, this has a theory, and I also uploaded a One Health transdisciplinary book chapter on that. The theory about this is transdisciplinarity, that we bring together scientists, communities, and authorities on one table and discuss and listen what are the local priorities, and then really find solutions in participation, co-producing knowledge from the technical knowledge and the practical knowledge of communities and authorities. In this way, we found solutions we would never have imagined. And as you said, working closely with communities and the local authorities is essential for the sustainability and integration of these systems into the state and provincial systems, but also in the village ownership of integrated community-based surveillance. Thank you very much.
Great, thank you so much. I think they're really great comments. I'm going to combine a few of the questions that we've got because they are reoccurring and I think a really important discussion topic to touch. And just ask the either speakers or panelists to raise their hand if they'd like to add. But we've received several questions about how can community-based surveillance be done in urban contexts as well as rural contexts. There's been a lot of different examples within rural contexts, but I mean, I do also know that CBS is done in urban contexts, and how does this look different? And then linked to that, there have been several questions about, is community-based surveillance also useful and relevant when it comes to wealthier countries or stronger surveillance systems? Is this still a useful tool? And are there examples that anyone would like to share on kind of the different contexts and how those are approached? So I'll hand that over. I see, Hilary, you have your hand up first. So I think I hand to you first, Hilary. And then Aaron, I'll go to you. Thank you.
Thanks, Rachel. I'll only address the first one around urban settings, actually. And I don't know, we've got a lot of people on the call. I don't know if we have people from Latin America here. What I'm aware, and I'm working closely with a group in Brazil, that event-based surveillance, community-based surveillance is quite less developed in Latin America than it is in Africa in the form that we're talking about. And one of the things that this group, which is based in Brasilia and also working in Capo Verde, so they're trying to cross the divide, obviously Portuguese speaking, but they are looking at two different scenarios, is what is it that you can, how can you define your community, your parameters, and how can those community leaders be chosen and selected to be representative? And then how can, again, I go back to this, how can they be involved from the beginning to make it sustainable beyond your pilot period of 6-9 months when everybody's enthusiastic and then suddenly the excitement goes. So what, and I think this, we talk about villages, but actually urban areas are defined areas. There are very clear areas, as I understand, in Brasilia where the community leaders know that they are covering a certain area, they are representative for that. So with that, at risk of repeating myself, I think it's in urban areas as in rural areas. It's a case of really first getting to know your community, not just thinking, oh, we're going to roll out event-based surveillance, community-based surveillance, and thinking it will just go like this because it's a, you know, everybody's going to work the same way. Over.
Thank you so much, Hilary. And also, Dr. Arun, I think you have a lot of experience in this as well. And so it would be great to hear some examples from you and some feedback and suggestions. Thanks.
Yeah. So thanks. So I think it's a really interesting question, something that we at the Global Fund have also been trying to explore, the question about how is the community event-based surveillance, community-based surveillance relevant in urban settings. And I also noticed the time. So I will just be really quick, you know, we are, just like Hilary mentioned, we're defining communities differently, and we're defining also communities at the urban settings very differently. And examples come from our COVID-19 experience. And one of the examples came from Philippines, where during COVID-19, because it's ultra-urbanized cities in Philippines, they actually used apartments, large apartments with many communities living with the apartments, and they defined that as a community, and they engaged the apartment manager there as their focal point. And it really worked well for them, because in urban settings, it really doesn't fit the structure of what we think about community health worker. So just thinking about communities differently in other urban settings, I've also seen where you know, refugees or transient workers from their own communities, and you find your key focal points there. So to the point that we've all been making, I think we need to start thinking about communities very differently from what we've been thinking about before, whether it's rural or urban or peri-urban. And how do we then engage those communities to be our key focal points? It becomes particularly important in urban areas. I mean, we also see this in the MPOX in DRC, where most of the hot zones are in Kinshasa, highly urbanized settings where routine community health workers set up is not seem to work. So I'm happy also to discuss how we're thinking about this in Kinshasa for MPOX. But I want to leave this audience with the final thought that we really need to define communities very differently and find the focal point within these communities who can help us, you know, do pandemic preparedness differently than what we've been doing before. Thank you. Over.
Thank you so much, Arun. A lot of that resonates from some of the work we did in Dhaka and Bangladesh as well. So I think it's a really great point. Dr. Philippe, I think there's just 1 more minute left, if it's possible to be brief, and then I will hand it back over to Lester for the closing. Apologies, Dr. Philippe. I think I'm having trouble hearing you. I don't know about others in the audience.
Aaron, the success of community-based surveillance in urban setting and rural setting really depends on the social and administrative systems that exist in a particular area. Sorry. So our experience are not very successful in the informal settings of urban areas and the rural communities. And I think, like I've said, this largely is guided by the administrative and social structures that exist in any particular place. Yeah. Thank you, and back to you.
Great points. Thank you so much for sharing. Lester, I think I will hand it back to you for closing, but also just a really big thank you for all of the panelists here, for the work done, also supporting on the chat by colleagues from the Community of Practice for CBS. So thank you so much for joining today. Lester, let me hand it back to you now. Thank you.
Thank you very much, Rachel, and our panelists and speakers. So a lot of learning there from different countries and different experiences. Finally, we are at the end of our allotted time. I will wrap up by saying thank you very much to our speakers and panelists today, the WHO colleagues who have worked on this, and the EPIWIN team. Big thanks also to the working team who supported the preparations for this webinar, including the Interagency Community of Practice for Community-Based Surveillance. Finally, thank you all for coming and for your active participation through the Slido survey and through the question and answer. The recording of this webinar will be available at the EPIWIN website and EPIWIN Digest. A slide set with key messages on this topic will also be published shortly. If you want to keep updated on future EPIWIN webinars, recordings, and presentations, and the EPIWIN Digests, please subscribe to our mailing list. Both links are provided on the chat. We hope you will also join us for our next webinar. It will be next week, Thursday, on the 21st of November at 2 p.m. Geneva time. The topic is Launch of MERS Tracker, an interactive dashboard to support evidence-based decision-making. Details are already posted on the website and are sent to the mailing list. So thank you all. Thank you very much, and goodbye. See you next time.